Okay, well, I hope you can see my slides now, but let me know if you can't. Well, good afternoon or good day, everyone, and welcome to Pediatric Teaching again today. I wanted to talk about anemia today. In the talk so far this year, we've talked about some very common problems, haven't we? Acute respiratory infection and pneumonia. We've talked about fever. We've talked about the deteriorating child, and a number of other things. And today I want to talk about something that's very common again. It's really, we see it almost every day in our clinical practice. And there'll be a number of lectures given throughout the year that'll actually cover various aspects of anemia. But I wanted to cover just a few aspects to start with today. So we'll make a start today. As I said, anemia is really common. We see it in around about 12% of our patients in hospitals, and I want to cover today just some basic things about the physiology of hemoglobin and oxygen delivery. For us to, I think as pediatricians, we really need to understand anemia really well. If we understand it, then we'll understand a lot about blood, about full blood examinations, about the hemopoietic system, about nutrition, about febrile illnesses and malaria and chronic illnesses, and then congenital problems causing anemia. So I think anemia is something, if we can really understand in a lot of detail, it'll make us much better, both an understanding of the pathophysiology of anemia and also the clinical manifestations. So today we'll talk about the physiology of hemoglobin and oxygen delivery. Just briefly on that, we'll talk about how to assess the child with anemia or the very pale child. We'll speak quite a bit about iron deficiency because it's such an important cause of anemia. And I want you to understand quite a bit about iron physiology and how the body deals with iron. We'll talk quite a bit about thalassemia because it's such a common cause of congenital anemia in children in Papua New Guinea. And we'll just briefly touch on sickle cell disease, which is much less common in PNG, but does occur usually in combination with thalassemia. So, but as I say, there'll be other talks throughout the year where we'll talk about other aspects of anemia, such as hemolysis and other types of anemia, but we'll just start with this today. I want to start with the oxygen delivery equation because it tells us why hemoglobin is so important and what happens when a child's anemic. So this is how much oxygen is delivered to cells. The DO2 is how much oxygen is delivered to cells. The CO is the cardiac output. So the amount of oxygen that's delivered to cells is dependent on the cardiac output times the hemoglobin times the oxygen saturation and then times a factor. And I think you all know that the cardiac output is the heart rate times the stroke volume. Oxygen delivery, as I said, is DO2. It's the cardiac output times the hemoglobin times the oxygen saturation. So if you think about those three things, cardiac output, hemoglobin, and oxygen saturations, they're things that we assess all the time in our patients. And if a child's hemoglobin is down, then their oxygen delivery will be down unless their cardiac output increases substantially. And so that's why you see in children who are very anemic, why they have a high cardiac output. They often have a bounding circulation, hyperdynamic circulation, because their heart's having to pump a lot more blood to deliver the same oxygen to the tissues. In a similar way, if you've got a child who's got a very low saturation, chronically low oxygen saturation, they might have tetralogy of Fallot, or they might be living at very high altitude, then their hemoglobin level will often be higher. They'll adapt to having a higher hemoglobin, unless of course they've got anemia. But it's the interplay between cardiac output and hemoglobin and oxygen saturation that becomes very important in understanding anemia and how it affects children. There are substantial age changes with hemoglobin throughout childhood, and I'm sure most of you know that the hemoglobin in newborn babies is actually much higher. It's usually around about 12.5 to 15. It can be even higher. So this is the average. The average of hemoglobin of children of mothers who had without any placental malaria. You can see that if a mother has had placental malaria, then the hemoglobin is a little bit lower. But the main message is the normal there's a normal variation, variation in the hemoglobin in the first 6 months of life, where the hemoglobin drops from around about 14 grams per deciliter to around about 100 to 120. And that mostly occurs because when babies are born, they have two sorts of hemoglobin. They've got some adult hemoglobin and they've got fetal hemoglobin. And the reason why there's more hemoglobin at the time of birth is that the fetus is used to existing in a hypoxic environment. So again, going back to that oxygen delivery equation, if you've got a hypoxic environment, then generally you'll have a higher hemoglobin to deliver the same amount of oxygen around. It's important to know that young children, like from 6 months to 9 months, have lower hemoglobin than adults. And so if you're a child who's 6 months, usually their hemoglobin is about 95 to 115 or 9.5 to 11.5. But by the time of 2 years, it goes up to 11.5 to 12.5. And then, of course, there's a much greater change at the time of puberty. So there's a drop in hemoglobin in the first 6 months of life. That's when we say the hemoglobin's reached the nadir, which is the lowest point. And then there's a slow increase up to about the age of 2, and then the hemoglobin plateaus. And then beyond that, this is again data that shows that the hemoglobin level, again, from in girls and boys is a little different. This is from 1 year of age. It's going up, and for boys, there's a substantial rise in hemoglobin in puberty, and for girls, there's less of a rise. There's a rise early in life, so from about the age of 3 to 10 years of age, but it doesn't rise much more, whereas for boys, there's a continued rise from about 12 years of age until a boy has a hemoglobin around about 13 or 14 at the age of 14. I want to get on to assessing a child with hemoglobin, with anemia. And when you're assessing a child with anemia, there's many things you want to ask on history and on examination. The first thing you should ask is the child sick or well? And here's 2 children that have got anemia, and it might surprise you to know that the hemoglobin of the small baby who's got needing lots of oxygen and looks very unwell has a hemoglobin of 6 grams per deciliter. And this older boy who is awake and alert and doesn't look very unwell has a hemoglobin of 1.6 grams per deciliter. So a child can have a very low hemoglobin and not seem very unwell, or they can have a moderate hemoglobin and be very unwell. And the reason for that, of course, it depends on the rapidity of onset of the anemia. Obviously, if you have very rapid onset anemia, you're going to become more unwell. If you have a slower onset, a sort of more chronicity to the anemia, then you may not become as unwell because you'll adapt in some ways, but you'll still have some level of borderline decompensation of your cardiac and your respiratory system. And that's what, when we're assessing a child with anemia, we need to know whether they've got a fully compensated cardiorespiratory system or whether it's borderline decompensated or fully decompensated. This boy, this older boy, despite him not looking very unwell, with a hemoglobin of 1.6, had a heart that was almost the size of his thoracic cavity on chest X-ray. So it just tells you that he had borderline cardiac decompensation, even though he didn't look very unwell. And this younger baby who had a hemoglobin of 6, obviously lost hemoglobin rather quickly and had an infection. So it's the underlying cause of anemia that dictates whether the child's very unwell. So when you're taking a history from a child with anemia, there's a number of things you need to cover. One, you need to try to understand whether the anemia is acute, like it's just happened quite recently, or whether it's chronic. And you can try to understand that by the questions you ask about the duration of the child's symptoms, whether it's lethargy or the parents have noticed pallor, etc. You need to understand quite a lot about the perinatal history, and we'll explain why that is later. So even in a child who's 3 or 4 years of age, the perinatal history in a child with severe anemia becomes quite important. You have to understand a lot about the dietary history. And I think it's useful when you take the dietary history of a child who has anemia, then take it in two ways. One is a cross-sectional history of how much the child eats at the moment and what the child eats, how frequently, etc. And one is a chronological history about their diet from the time of birth. Were they breastfed exclusively at birth? How long were they breastfed exclusively for? When did semi-solids begin to be introduced? What sort of solid feeds was the child on from 4 or 6 months of life? What's the complementary feeding is like, etc. Over a chronological history over time. Even if a child's 3 or 4, it becomes very important to take a full and complete dietary history. With the cross-sectional history of finding out what the child eats on a typical day, you might ask questions like, in a typical week, how many days does the child eat meat, or does the child eat vegetables? And many children are eating 2 meals a day, sometimes with snacks, and the meals might only be fruits rather than vegetables and not much protein. So you need to really bring that type of dietary history out. You should ask a gastrointestinal history, because that will speak to whether or not the child's got any gastrointestinal blood loss, or whether they've got any evidence of a malabsorption syndrome that might lead to iron deficiency or deficiency of other hematinics. Should always ask about medications or drugs the child's been exposed to, or any chemicals, because sometimes the child will have been on a medication that will suppress bone marrow function. Ask about bruising or bleeding and about infections, because you want to find out about the other aspects of the blood, isn't it? Sometimes when a child has anemia, often it's only the red cells that are affected, but sometimes the platelets and the white cells will also be affected by whatever the underlying process is. So asking those basic things at the start can really help. Then ask also about comorbidities or other illnesses the child has, and ask about a family history, because there are many different causes of anemia where there is a family history involved, whether it's thalassemia or sickle cell disease or hereditary spherocytosis or some other form of red cell membrane defect. You need to ask a family history. When you're examining a child with anemia, then of course, first of all, look for emergency signs, because the signs of respiratory or cardiac decompensation are all emergency signs: severe respiratory distress, cyanosis, hypoxemia, etc. So you need to look for the airway, the breathing, and the circulation. Decide whether the child's sick or well, which again relates to some extent what the underlying condition is, what the underlying cause of the child's anemia is, and also relates to whether it's acute or whether it's chronic and how well compensated it is. Look at the skin for pallor. In the older boy I showed you before, you could see the palmar pallor that he had, and his tongue was very pale. But also look in the conjunctiva for pallor. Look for petechiae in the skin or bruising, because it might tell you something about whether there's other elements of the bone marrow that are also affected, other elements of the blood that are also not working well. Look in the conjunctiva for pallor and jaundice, as I said, because some types of anemia will give you jaundice because of hemolysis. And then look for a hepatomegaly or splenomegaly or enlarged lymph nodes. Also look for growth failure. Many children with anemia have growth failure either because of an underlying problem with their nutrition or because of a congenital problem that leads to both anemia and growth failure. Then look for evidence of chronic illnesses and look for congenital abnormalities, because there are some, although rare, forms of anemia that are associated with congenital abnormalities of the limbs, or other abnormalities that might suggest, for example, thalassemia. When you think about anemia per se, there are broadly 3 causes, and you can think of anemia in this way: that there's reduced red cell production, that is, the bone marrow is not making enough, or there's increased red cell destruction, that is, the bone marrow is making enough red cells, but the red cells don't have the normal duration of life. The red cells don't have the normal duration of life that normal red cells do, because they're being hemolyzed or being destroyed somewhere in the bloodstream or by the spleen early. So increased red cell destruction. And then the last one is red cell loss, either bleeding somewhere, and it could be acute hemorrhage, or it could be occult gastrointestinal bleeding, or it could be bleeding from the urine, etc. There's if you think about all the different causes of anemia, and there's many dozens of them, then they all are either reduced red cell production or increased red cell destruction or red cell loss. And when we think about anemia, we can think about the different types and how they fit into this these three categories. I'm going to talk a bit about reduced red cell production because it's the most important cause of anemia. And mostly the most important cause is iron deficiency. But there are other causes of reduced red cell production, including folate deficiency or B12 deficiency in some children, in some circumstances. And then there are some other conditions that give you reduced red cell production, not because there's a component of making hemoglobin that's absent. So iron is required for hemoglobin, folate is required for hemoglobin, and B12 is required to make hemoglobin. It's more because the bone marrow has failed for some other reason. And the bone marrow can fail because of aplastic anemia, or because the bone marrow is being replaced by malignant cells like leukemia or malignancy or some congenital storage disorder, or because there's a chronic infection and that leads the bone marrow to be suppressed, or there's some congenital problem, like there's a condition called congenital red cell aplasia, Black-Van-Diamond syndrome, don't need to worry about it, or chronic renal disease can lead to reduced red cell production, a bone marrow failure condition because of a lack of erythropoietin. If the kidneys are failing, then they stop making erythropoietin, and then the bone marrow will fail as a secondary event. And then sometimes there can be an inflammatory destruction within the bone marrow, and that's called hemophagocytosis, where the bone marrow, there's an inflammation within the bone marrow and usually within the bloodstream as well, but it's destroying red cells and other blood elements before they can be released into the blood system. I want to talk mostly about iron deficiency, though, because it's the most important and common cause of anemia that we see. We'll talk a bit about hemolysis at a later lecture, I think, but just to know, there are broadly two types of hemolysis. One is immune hemolysis related to antibodies, and the other one is non-immune hemolysis. And I've already mentioned a few of these before, but there are some defects in red cell enzymes like G6PD deficiency, some defects in red cell membranes, that is the membranes that surrounds the red cell, so spherocytosis and elliptocytosis. And then there are some defects that involve the hemoglobin itself, the peptide change of the hemoglobin, which we'll talk a bit more about today, thalassemia and sickle cell disease. And then occasionally hemolysis occurs because of physical forces, like the malaria parasites. When they infect red cells, leads to physical forces on the red cells because of a deformation of the shape of the red cells. And there are other physical disruptions to red blood cells that in sepsis that can lead to hemolysis. So we won't talk too much about hemolysis today, but we'll cover that in another lecture. I wanted to talk about how we read a full blood count, because we often get full blood examinations, but I don't think we spend that much time in reading them properly so that we really understand how to read a full blood count in a child with anemia. If you look first at of course you look first at the hemoglobin. That's obviously the amount of hemoglobin in grams per deciliter usually, or grams per litre in the blood. You then look at the MCV, the mean cell volume, MCV, and that tells you about the size of the red cells, the volume of the red cells. You then should look at the RBC, which is the red cell numbers, not the volume of the red cells or the amount of hemoglobin, but the actual number of red cells that can be seen per ml of blood. Then you next should look at what's called the RDW, and it's the red cell distribution width. And these four parameters, hemoglobin, MCV, RBC, and RDW, are on almost all full blood examinations, but we often don't look beyond the hemoglobin. But I want you to try to look at all these four parameters, because from those four parameters, you can tell a lot about what the underlying cause of the anemia is. The RDW refers to a variation in the size of the red cells. So when you've got a high red cell distribution width, then you'll have a lot of small red cells and a lot of large red cells and some in the middle. So you'll have a wide variation in the size of the red cells. Whereas normally with most of our blood films, there's a more uniformity of the size of the red blood cells. You then should look, well, this isn't always on all full blood counts, but sometimes if you ask the laboratory, they'll count the number of reticulocytes. And this requires the look at the blood film under the microscope, usually, to count the number of reticulocytes. And reticulocytes are new red blood cells that have entered into the peripheral blood. And usually the number of reticulocytes in the peripheral blood will usually be about 1%. But sometimes when you've got some cause where the blood is breaking down quickly, or you've got blood loss from, say, iron deficiency, particularly if you've got hemolysis or blood loss from the gastrointestinal tract, then the number of reticulocytes will be quite high. It might be 4 or 5, 6% of all the red blood cells. And that tells you that the bone marrow is working overtime. It's producing a lot of very young, immature red blood cells and putting them out into the circulation. So that's what reticulocytes tell you. And then you should look on the full blood examination, just on the FBC that comes from the computer. You should look for other clues to bone marrow failure. And those other clues, they're not conclusive, but if you saw both the hemoglobin being low and the platelets being low and the white cells being low, then you'd suspect that there's some element of bone marrow failure. That is, the bone marrow is not producing enough red cells and there's some element of bone marrow failure. So you can learn a lot by looking in detail at the full blood count. And I just want to try to explain what in the common causes of anemia, what these parameters look like. So when, as I said, you first of all should look at the hemoglobin and see whether that's high or low, of course. The next thing you look at is the MCV, the mean cell volume. And you can divide up the types of anemia into those that have a low MCV, that is, it's microcytic, those that have a normal MCV, it's normocytic, and those less common that have a high MCV, it's macrocytic anemia. Let's talk about the low MCV types of anemia. Most of the low MCV types of anemia we see will have an element of iron deficiency. And if the MCV is low, then look again at the red cell distribution width. And the reason for that is when you've got iron deficiency, you have a wide variation in the size of the red blood cells. So you'll have a high red cell distribution width. Also, because you've got iron deficiency, your bone marrow is not making enough red blood cells as well. Not only enough hemoglobin, but also not enough red blood cells. So the red RBC, the number of red blood cells, will be quite low. So the red cell distribution width will be high, and the red cell counts, the RBC, will actually be low. Now that's typical of iron deficiency. But if you see that the red cell distribution width is normal and there's a normal RBC, then you start thinking that the child might have thalassemia. And that's because in thalassemia, the bone marrow is typically making new red cells, so that you often have the right number of red blood cells, and they're not very abnormal red blood cells. They're not like differences in sizes and shape, like with iron deficiency. So the red cell distribution width is usually within the normal limits, and the RBC is often within the normal limits. And of course, those children will have clinical features, usually of splenomegaly or hepatomegaly or frontal blossing, and that they're likely to have thalassemia. But if you see a child who's got a low MCV and they've got a high RDW and a low red blood cell count, then you can ask the laboratory to look for reticulocytes. And mostly these children with iron deficiency, if it's established iron deficiency and they have severe anemia, they'll have a low reticulocyte count, typically low, if they've got iron deficiency. If they've just got blood loss and they're still making lots of red blood cells, then sometimes their reticulocyte count will be normal or high. But if they've got severe iron deficiency, then their reticulocyte count will be low. Then, of course, you ask about a dietary history in more detail and ask about blood loss. And you can really make a diagnosis of iron deficiency by just going down that pathway. If you've got a patient who's got a normal MCV, then they've got normocytic anemia if they've got their hemoglobin's low. And these patients also fall into two categories. You can ask the laboratory to measure reticulocytes and see if it's high or low. Now, if the reticulocytes are high, then you start thinking that maybe they've got some hemolysis, but they'll also have a high bilirubin, they'll have splenomegaly, they may have other things too, other features of hemolytic anemia, and then you may be able to do something like a Coombs test. We'll talk more about hemolytic anemia at on another teaching session, I think. If the reticulocyte count is very low in a normocytic anemia, then that suggests that the child's got bone marrow failure. And you should be therefore then looking at things like anemia of chronic disease, or for signs of leukemia, or chronic kidney disease, or TB, or a drug history, anything that might cause the bone marrow to fail. And then lastly, if you've got a child who's got a macrocytic anemia, then find about the macrocytic anemia being a high MCV, then seek the dietary history in the child and the mother, and seek it in a lot of detail. Most children with macrocytic anemia have very unusual diets. They might just be, for example, treated with, they might just be fed with fruits, for example, and have no protein or eggs or vegetables that can be sources of folate or B12. And sometimes a child with a macrocytic anemia with B12 deficiency, the mother will also have anemia. There might be a breastfed baby of a mother who's got what we call pernicious anemia, or got B12 deficiency. So these are rare and uncommon events. But if you see macrocytosis, then they're on the full blood count, then you need to go down that pathway. Okay. So just to reiterate again, usually with iron deficiency, the most common form of anemia we see, then the MCV will be low, the red cell distribution width will be high, the red blood cell count will be low, and the reticulocyte count will be low. If the patient has thalassemia, then sometimes the MCV will be a bit low or normal. The red cell distribution width will be normal. The red blood cells will usually be normal, and the reticulocyte count will be either normal or high. And again, we'll talk about hemolysis and B12 deficiency, I think, at another time. But you can just by looking at each of these parameters in a child who's got anemia, more or less work out what the likely cause is. This is the blood film of a child who's got iron deficiency anemia, and what you can see is that the red cells look very pale. I don't expect you to be looking too much at blood films, but it's good to sort of know what the blood film looks like of a child who's got the commonest causes of anemia. So this is a common cause of anemia where you get what's called where you get very pale cells with target cells. So they've lost all their hemoglobin. The pigment inside the cells is not there, but you can see this what's called a target cell where you get a red circle and a red circle in the middle, surrounded by most of the cytoplasm of the red blood cell being pale. And then you get these cells called elongated cells or just misshapen cells. And you can see there's a wide variation in the size and the shape of the cells. It's a microcytic anemia with what we call poikilocytosis, which is a wide variation in size and shape. And then, of course, because of that, the red cell distribution width is very high. There's a wide variation in size and shape, and that's why the RDW is high when you do the full blood count. I want to talk a bit about iron physiology. I think you might know it, but it's good to know how we absorb iron and how our body regulates the amount of iron we absorb. And most of our iron is absorbed in the small bowel, and it's absorbed whenever we eat iron-containing foods, whether it's meat or green vegetables. Then the iron is absorbed by the gut mucosal cells. So we've all got mucosal cells lining our gastrointestinal tract, and the iron is absorbed into them. Now, there's a feedback loop which says that if the body's iron stores are high, then the iron is not absorbed into the bloodstream, but the gut mucosal cells shed the iron when it's lost, because the gut mucosal cells are turning over every 2 or 3 days. They are replenishing and rejuvenating every 2 or 3 days. So if there's a deficiency of iron in the blood or in the body, then that iron is absorbed into the blood. And if there's not, it just stays in those gut mucosal cells and is sloughed off when those mucosal cells are shed a few days later. It's important to know that iron's not just used for hemoglobin, but also for other enzymes and other proteins within the body. So it's used for myoglobin, which is within muscles, and also iron-containing enzymes, including neurotransmitters in the brain. And that's why I think some children with severe iron deficiency have cognitive impairment. They will have problems with thinking, they'll be slow with their schoolwork, and it's partly because they may have reduced oxygenation to their brain, reduced cerebral blood flow or reduced cerebral oxygen delivery, but also because you need iron for neurotransmitters. So if you don't have iron, then many of the synapses work a bit slower within the brain. So it's just important to know that iron's not only used for blood, but also for muscle and for other iron-containing enzymes. Most of iron is in storage form. So what we measure in the bloodstream is actually a very small amount, whereas most of the iron's in either stored as ferritin, which we can also measure in the blood, or hemosiderin, which is in the bone marrow, in the liver and in the spleen, or it's bound to plasma proteins. So when we measure the serum iron, we're measuring quite a small amount of the iron in the plasma. And so it's the iron itself is not always reflective of whether the child's iron deficient. And that's why we usually need to measure the ferritin as well. And sometimes mostly the ferritin and also what's called the total iron binding capacity, which is the amount of plasma proteins that are not bound to iron yet, which tells you if there's a high total iron binding capacity, it means there's not much iron circulating. So from the ferritin and the total iron binding capacity and the serum iron itself, you can usually get a good idea whether the child's iron deficient. But if you don't have iron studies, if you can't do iron studies, the ways I showed you before, looking at the hemoglobin, the MCV, the red cell distribution width, and the RBC, and reticulocytes, if you can do it, is a good way to diagnose iron deficiency. At birth, most children have around about 250 milligrams of iron. That is, a 3 kilo child has about 250 milligrams of iron, so about 75 milligrams per kilogram. Now, an adult has somewhere between 2 and 3.5 grams of iron. So there's a big difference between the amount of iron a baby has at birth and the amount of iron they need to have when they're an adult. And so that means you don't make iron in your body. You only all our iron comes from our diet. And so a child throughout childhood, infancy and childhood needs to accumulate a lot of iron, needs to ingest a lot of iron in food to be iron replete, that is, have enough iron when the child becomes a teenager and needs about 2 to 3.5 grams of iron in the body. And so the iron requirement in the first year of life is somewhere between 150 and 200 milligrams of iron in the first year of life, or 1.5 milligrams of iron per day. And I'll just explain about low birth weight babies and iron, that if a baby is born at 1 kilo of their birth weight is 1 kilo, then they only have about 75 milligrams of iron instead of 250 milligrams of iron. If they're 2 kilos, then they might have 150 milligrams of iron instead of 250 milligrams of iron. And so the point being that a low birth weight baby has to take in a lot more iron than a baby of normal birth weight if they're going to achieve the same amount of iron in the body at 1 year of age. Now, for the first 6 months of life, breast milk is a very good source of iron for the first 6 months of life. If a mother is not iron deficient, if she's got enough iron, then human breast milk is a very good source of iron for 6 months. After 6 months, human breast milk is an inadequate source of iron. It's not enough. It's good, it's still good, but it's not enough. And that's why the child from 6 months of age onwards must be on some iron-containing complementary feeds. Otherwise, the child will become iron deficient. And what we see commonly is from about 4 months of age, typically as breastfeeding wanes and complementary feeds are introduced, but not very good quality complementary feeds, then infants become iron deficient. Human breast milk is a much better source of iron than cow's milk. So there are some children that are fed on cow's milk, whether it's sunshine milk or some other form of milk. That is a very poor source of iron because not much of it can be absorbed, unlike with human breast milk, where about half of the iron in human breast milk can easily be absorbed. If a child's on cow's milk, then most of it is not absorbed. But both are relatively low in iron for the child beyond 6 months of age. Good enough human breast milk is good enough up to 6 months of age, but beyond that, it's not enough. It also, of course, depends on the amount of iron a mother has, and that's why iron supplementation of mothers is a good idea as well. Breastfeeding mothers. There are many reasons why iron deficiency occurs. It's not just because the child's not getting enough, but there are some reasons why a child might have increased requirements for iron. That is, they might be low birth weight babies. So as I said, they don't have as much iron crossing the placenta. The reason why preterm or low birth weight babies don't have as much iron in their body is because most of the iron crosses the placenta in the 3rd trimester. And so if a baby's born late in the 2nd trimester or early in the 3rd trimester, then most of the iron has not crossed the placenta and hasn't got into the fetus. And so low birth weight babies have iron deficiency because of that reason, and also because often when a low birth weight baby's in the nursery, we might take blood from them. When you're taking blood from a low birth weight baby, a preterm baby, you're also removing iron. And so it's really important that we try to minimize the amount of blood taking because you're taking iron from that baby. In the first year of life, then babies have rapid growth, and also during adolescence, children have rapid growth. And there are times when if the child's not taking more iron, then they may become iron deficient. As I said, there are some, when you're taking a history for a child who's got anemia, then take a perinatal history, because there is sometimes evidence of blood loss at the time of birth, either because of feto-maternal hemorrhage or feto-fetal hemorrhage, or placental abruption with hemorrhage, or an umbilical bleed. There may be some reason why there was some blood loss at the time of birth leading to less iron. And as you know, that these days delayed clamping of the cord leads to a higher level of hemoglobin at 6 and 12 months of age. Why? Because there can be some more blood flowing from the placenta into the baby, and so they just get a little bit of a rush, a transfusion of the blood from the placenta if you delay clamping of the cord. Iron deficiency occurs quite commonly, of course, also because of inadequate intake of iron, and especially diets that are rich in milk. Like if a child has been drinking a lot of cow's milk, then typically they're not eating much meat or vegetables. So if the child's diet is poor, that is, it's not a balanced diet with a wide range of iron-containing foods, meat, cereals, vegetables, they're all iron-containing foods, then fish as well, then a child is likely to get iron deficient. And they may fill up themselves with milk, often cow's milk, and not take any other food. Sometimes there'll be malabsorption, like children who have persistent or chronic diarrhea for whatever reason may have malabsorption of iron, or rarely in children who've got celiac disease and other congenital form of malabsorption, they may have it. Blood loss is a common cause of iron deficiency, and it usually is coupled with nutritional deficiency. So you've got children who have hookworm infestation and they also have nutritional iron deficiency. That the coupling of those two conditions is probably the world's most important cause of anemia and iron deficiency. Some children who drink a lot of cow's milk will have an allergy to cow's milk, and they'll have gastrointestinal blood loss, and because of inflammation of the bowel. So cow's milk protein allergy is relatively common, and they may lose hemoglobin and blood from gastrointestinal blood loss. And then the last cause is not last cause, but in adolescent girls, because they're rapidly growing and also because they're having to starting to have periods and losing iron during that, they of course need more iron supplementation at the start of their teenage years. So there's lots of different causes of iron deficiency. We're not talking about at the moment the other causes of anemia, but we're just talking about all the different causes of iron deficiency, and there's lots of different causes. So it's important on the history and on the examination to try to identify the cause and then replace the iron. The treatment of iron deficiency is quite simple. You identify the cause if you can, you replace the iron, and you give dietary advice. And obviously iron is contained in a lot of different foods. It can be in red meat or white meat, but even in children who don't eat meat or don't have much protein intake, they can maintain their iron stores by having beans or cereals or green vegetables or egg yolk. Egg yolk has quite a good amount of iron. And so even as a vegetarian, you can maintain your iron levels without eating meat if you want to. But you need to, regardless of your type of diet, you need to have a balanced diet, and otherwise a child will become iron deficient. You can prevent iron by giving iron deficiency by giving about 1 milligram per kilogram per day of elemental iron, and that's really a diet that's fortified in cereals or meats or green vegetables, but not just fruits and milk. Fruits and milk will lead to iron deficiency, and I think that's one of the reasons why we see it so commonly. If you're looking after a low birth weight baby, they need to have twice the amount of iron, and that's why we typically start iron replacement for those infants at around about 4 to 6 weeks of age, so that they can catch up, if you like, on the iron that they didn't get when because they were born prematurely. When you're looking after a child who's got iron deficiency and you're putting them on iron, then you should tell them to take the iron with orange juice to aid absorption, warn them that when they take iron, the child's stools will be black, because sometimes the parents stop the iron, giving the child iron because they're worried the stools are black. And also iron causes constipation, so it's really important that you warn parents of that and do things to change the diet to avoid that. So sometimes so if a child's on a lot of milk, then they often will have constipation anyway, and if they're taking iron as well, then they almost certainly will. So it's important that you try to avoid that. Otherwise, the child will stop taking the iron and they'll remain iron deficient. I always tell parents to brush their teeth after giving iron, because there's a small risk that it will cause staining of the teeth. And it's important, if you're giving a child iron in iron tablets or iron elixir, that you tell the parents that they should keep the iron out of reach of the children. Very important. It's been a while since we saw a child with severe iron toxicity, but if a child has a big ingestion of iron, then they often get severe gastrointestinal bleeding or stricture of the gastrointestinal tract, or they may even get gastrointestinal perforation. It can be a very toxic compound if taken in overdose. So keep it out of reach of children. Orange juice helps to aid absorption, just like any form of vitamin C will aid absorption of iron. So it's good to take iron with vitamin C. Now, I think maybe we'll stop there. We've covered quite a lot about different forms of anemia. I think perhaps next week we might talk about thalassemia and sickle cell disease, because there's a lot to cover. So I might just stop there and see if anyone's got any questions about what we've covered today, which is the different types of anemias and how to recognize them based on the full blood count, and how to all about iron physiology and how to identify iron deficiency. Next week, I think we'll talk about thalassemia and hemolytic disease in a variety of different forms. So I think we might stop there, because it's coming up to the hour, and rather than go on, does anyone have any questions about what we've talked about today, or any comments about anemia?